Lymphocyte precursors originate from the pluripotential hematopoietic stem cell in the bone marrow. They differentiate into T, B, and NK cells, all involved in the immune response. Lymphocyte size varies, and counts differ significantly between newborns, children, and adults. Lymphocytosis, or lymphoproliferative disorders, occurs when the absolute lymphocyte count exceeds 4.0 times 10 to the 9 per microliter in adults, or 9.0 times 10 to the 9 per microliter in children. It's often a self-limiting reactive process in response to infection or inflammation, usually affecting both T and B lymphocytes. T lymphocytes typically make up 60 to 80% of peripheral blood lymphocytes. Absolute lymphocytosis usually isn't accompanied by leukocytosis, except in conditions like infectious mononucleosis and lymphocytic leukemia. Relative lymphocytosis, secondary to neutropenia, is more common. This video will now review the causes of lymphocytosis. Infectious mononucleosis is a self-limiting lymphoproliferative disease caused by the Epstein-Barr virus, or EBV, and typically affects young adults. EBV attaches to the CD21 receptor on B lymphocytes, starting the infection in the oropharynx before spreading to the blood. The body controls acute EBV infection through a complex cellular immune response. In the second week of illness, CD8+ cytotoxic T lymphocytes and NK cells decrease the number of immunoglobulin-secreting B lymphocytes. The reactive lymphocytes seen in peripheral blood are primarily these CD8+ T lymphocytes. Early symptoms of infectious mononucleosis include lethargy, fever, and a sore throat. The classic triad includes fever, pharyngitis, and lymphadenopathy. The disease typically resolves on its own within a few weeks. Lab findings for infectious mononucleosis include leukocytosis due to absolute lymphocytosis, with lymphocytes often exceeding 50% of leukocytes. Reactive lymphocytes typically make up more than 20%. Immunoblasts and plasmacytoid lymphocytes are also commonly present early in the disease. Bone marrow aspiration shows hypercellular marrow, except for neutrophils. Diagnosis often involves testing for heterophil antibodies, VCA-IgM and IgG, and eBNA. Confirmation is achieved using the EBV PCR method. Toxoplasmosis results from infection with the intracellular protozoan Toxoplasma gondii. While infections are often asymptomatic, transplacental infection can cause severe fetal complications, including abortion, jaundice, and mental retardation. Peripheral blood films in toxoplasmosis show leukocytosis with relative or, less commonly, absolute lymphocytosis, including reactive lymphocytes. The heterophile antibody test is negative. Diagnosis is confirmed by seroconversion and a rising titer of antibodies to T. gondii. Cytomegalovirus, or CMV, can cause congenital or acquired infections. Congenital infection can lead to jaundice, microcephaly, and hepatosplenomegaly in newborns, with thrombocytopenia and hemolytic anemia as common hematologic findings. Acquired CMV spreads through close contact, blood transfusions, and sexual contact. It is common in immunosuppressed individuals and those receiving massive blood transfusions. Symptoms in adults are similar to infectious mononucleosis, but without pharyngitis. Laboratory findings for CMV include leukocytosis with absolute lymphocytosis and reactive lymphocytes. The heterophile antibody test is negative. Diagnosis is confirmed by demonstrating the virus in the urine or blood using a molecular assay or by a rise in the CMV antibody titer. Bordetella pertussis, which causes whooping cough, presents a blood picture similar to reactive viral lymphocytosis. The total leukocyte count is increased with absolute lymphocytosis of T, B, and NK cells, along with increases in neutrophils, monocytes, and granulocytes showing toxic changes. Persistent polyclonal B-cell lymphocytosis, or PPBL, is a rare disorder mostly found in adult female smokers. It involves a polyclonal expression of lymphocytes. While often asymptomatic, it can sometimes present with symptoms like fever or generalized lymphadenopathy. Lymphocytopenia is defined as an absolute lymphocyte count of less than 2.0 times 10 to the 9 per microliter. It results from decreased production, increased destruction, or changes in circulation. Corticosteroid therapy can cause a sharp drop by sequestering lymphocytes in the bone marrow. Causes of lymphocytopenia include malnutrition, disseminated neoplasms, connective tissue disease, Hodgkin's disease, chemotherapy, radiotherapy, and corticosteroids. It can also be seen with acute inflammatory conditions, chronic infections, and various immune deficiency diseases.